Your shoulder is screaming. The gallbladder's to blame. The phrenic nerve trap. Not all shoulder pain is cervical. Learn how the gallbladder refers pain via the phrenic nerve, when to investigate, and evidence-based treatments. This talk addresses a common misconception. Pain in the neck, shoulder, or even behind the scapula is not always cervical spine or myofascial in origin. In a meaningful subset of patients, the gallbladder and hepatobiliary system can generate referred pain to the right shoulder girdle via the phrenic nerve, roots C3-C5. Today we will review the neuroanatomy of referred pain, key clinical features that raise suspicion for a biliary source, an evidence-based diagnostic approach, and management options from lifestyle modification to pharmacologic therapy and surgery. Disclaimer: educational content only. This does not replace individual medical evaluation. Seek urgent care for severe or persistent symptoms. 1. Neuroanatomy of referred pain. The phrenic nerve provides sensory innervation to the diaphragm, with contributions from cervical roots C3-C5. Because phrenic afferents converge in the spinal cord with supraclavicular and adjacent somatic afferents, the brain may mislocalize visceral input, particularly from structures adjacent to the diaphragm, e.g., gallbladder, liver, subdiaphragmatic peritoneum, as pain felt in the right shoulder, the superior scapular region, or between the scapulae. Classic teaching includes right-sided scapular or shoulder pain with biliary colic. Boas sign, hyperalgesia below the right scapula, is historically described but is neither sensitive nor specific. The take-home point is the shared segmental innervation that enables hepatobiliary pathology to present as musculoskeletal pain. 2. Gallbladder physiology and why sludge, stones form. The gallbladder concentrates and stores bile produced by the liver, then contracts after meals, especially fatty meals, to deliver bile into the duodenum for lipid digestion. Biliary sludge forms when bile becomes overly concentrated or stagnant. This may evolve into cholesterol gallstones. Established risk factors include female sex, increasing age, obesity, pregnancy, rapid weight loss, prolonged parenteral nutrition, and certain medications, e.g., ceftriaxone. Exogenous estrogen exposure, including combined oral contraceptives, increases cholesterol saturation in bile and can raise gallstone risk. 3. When to suspect a biliary source for neck, shoulder pain. Consider hepatobiliary origin when there is right upper quadrant, RUQ, discomfort or fullness, often postprandial after fatty meals, that radiates to the right shoulder or interscapular region. Symptoms are accompanied by nausea and sometimes vomiting. Musculoskeletal only treatments, analgesics, massage, physical therapy, provide little or no durable relief. Important nuance: shoulder or neck pain does not automatically equal biliary disease. A clinical exam and, when indicated, imaging are essential. 4. Diagnostic approach. First-line imaging. Transabdominal ultrasound to identify gallstones, sludge, gallbladder wall thickening, sonographic Murphy's sign, and bile duct caliber. Pair with liver biochemistries, ALT, AST, ALP, GGT, and bilirubin, plus CBC if infection is suspected. If uncertainty persists, consider HIDA, hepatobiliary scintigraphy, to assess cystic duct patency and gallbladder ejection, MRCP for ductal pathology, or CT when broader differential diagnoses are being evaluated. Investigation should be individualized by the treating clinician. There is no one-size-fits-all algorithm. Self-pressure tests under the costal margin are not reliable diagnostics and may cause pain. Avoid them in favor of formal evaluation. 5. Evidence-based management. A. Lifestyle and diet. For patients with symptomatic gallbladder disease, many guidelines endorse reducing saturated fat, avoiding very large, fat-rich meals, increasing dietary fiber, and pursuing gradual, not crash, weight loss when indicated. Rapid weight loss is a known precipitant for gallstone formation and biliary colic. B. Pharmacotherapy, conservative measures. Ursodeoxycholic acid, UDCA, in selected patients with small, radiolucent cholesterol stones. UDCA can alter bile composition and gradually dissolve stones over months. Effect on biliary colic frequency is variable. It requires physician supervision, appropriate selection, and counseling about realistic expectations and recurrence. Taurursodioxycholic acid, TUDCA, a taurine conjugated bile acid with emerging data in cholestatic and cellular stress conditions. It is not a standard therapy for gallstone disease, and may be inappropriate when ductal obstruction is present. Any use should be clinician-directed. Over-the-counter self-experiments are discouraged. C. Surgery. For recurrent biliary colic, acute cholecystitis, or complications, laparoscopic cholecystectomy remains the standard of care. Timing depends on severity, comorbidity, and resource considerations and should be determined by the surgical team. 6. Red flags. When to seek urgent care. Seek emergency evaluation for persistent severe pain lasting more than 5 hours, fever or chills, jaundice, scleral or cutaneous, repeated vomiting, dark urine, or pale stools features suggestive of obstruction, cholangitis, or pancreatitis, which can be time-sensitive. Closing. Not all neck or shoulder pain stems from the cervical spine. When history and associated gastrointestinal features point toward the hepatobiliary system, a structured, evidence-based pathway, appropriate imaging, risk factor modification, select pharmacotherapy, and timely surgery when indicated, addresses the root cause rather than merely suppressing symptoms. Discuss your specific presentation with your clinician to tailor diagnostics and treatment. Disclaimer: this content is for general educational purposes only and does not constitute medical advice. Diagnosis, or a treatment plan. It is not a substitute for consultation with a licensed clinician. Any references to medications, supplements, tests, or procedures are provided as general information and are not individualized recommendations. Drugs and supplements may carry side effects, interactions, and contraindications. Always consult your clinician. The content is provided, as is, without warranties of any kind, including accuracy or timeliness. Your use of this content is at your own risk. By accessing this content, you acknowledge that you have read, understood, and agreed to this disclaimer. Turn on the bell for weekly, evidence-based updates. Like, share, subscribe.